Okay, at the outset, I would like to thank Professor Atul Kumar for including me in his course, which I've been doing for so many years. And I'll try to go over one of the most common condition which we face day in, day out, diabetic macular edema, the treatment options, and the managing kind of a recalcitrant diabetic macular edema. And I think DME is a chronic disease which require long-term strategies. Since the pathogenesis is multifactorial, we require multimodal approach. So I always emphasize that the first thing when we see a patient, very first day, write down the investigation, tell them to get investigated, blood glucose level, blood pressure, lipids, hemoglobin, HbA1c, 24-hour urine protein, blood urea, and serum creatinine. As well as that very day, we can always do these days at least fundus photo and OCT. Maybe FFA can be done subsequently as a baseline, or sometimes it may or may not be required, but still in most of the diabetic DME patient, we do FFA also these days, although the use has come down. And after this, uh, we have to achieve in them excellent glycemic control, normalize the blood pressure, and reduce the serum lipids. I think this earlier, Professor Atul has also emphasized that the lipids are very, very important. We have to treat anemia and proteinuria. We have good drugs for these. I think we have to talk to our these physicians or diabetologists that they should do everything together. I think I am showing you one very, very old patient here, that how the things would melt just in 3 months' time if you have a good strict metabolic, not only blood sugar, lipids, their proteinuria, everything goes down. This is without anti-VEGF and laser. That is what is required. So what are the treatment options? That is the basic topic. The treatment option for DME at this times are anti-VEGF agents, which we have three: ranibizumab, aflibercept, and bevacizumab. Of course, we have steroids, dexamethasone implant, fluocinolone, we don't have, Iluvien, triamcinolone, two of them. Laser still we have, and the laser use has come down. And this laser I'm not talking also much, but we do it in routine in many of our non-central involving DME. And of course, there is a role of surgery in cases of DME. So basically, we have these bevacizumab, ranibizumab, elpibrancept, or biosimilars. A lot of them has come, and all of them, they improve the visual acuity, decrease the macular thickness in DME, but the effect is temporary and repeated injections are required. That's where the problem is. I think the whole which anti-VEGF to use, that is always a question. So protocol T, which was over a 2 years period, clearly showed that all three, aflibercept, bevacizumab, and ranibizumab, had equal effect if the visual acuity was better than 612. So any one of them can be used. But in case the visual acuity is worse than 612, 20/50 or worse, then in that situation, I think elpibrancept has done much better in 2 year study. If the patient, and these days especially, I have seen after that scheme has come in, which is there with in some of us, so many of these patients do enroll now, and they get much better if their vision is worse. I think they fare much better. I think that is what I think in the morning session I was trying to mention about this one. This is the protocol I, persistence of edema. This is the post hoc analysis which has been done. And 1/3 of these patients experience persistent edema during the first year after initial ranibizumab treatment. That is the strict treatment, which is monthly almost. And in adjusted analysis, gains in vision improvement were lower for these very eyes at 52 as well as 104 weeks. So this is by Sada et al., which has been published in I 2020 here. And that is what is significant, that 1/3 still would have a persistent edema, which is a very important information according to me. So as far as the anti-VEGFs are concerned, early intensive treatment with anti-VEGFs in the first year lead to vision gain and can be maintained over a long period of time, and it may reduce also the treatment burden. We know in subsequent year, if we have not even treated that intensively, the injection required are much less. And aflibercept is the treatment of choice for the worst vision, worse than 20/46/12 if the patient can afford. And this is according to the protocol T as we have and is supported by the international guidelines. And approximately 1/3 have persistent DME. I think that is what we have to, or they are refractory to anti-VEGF, which may require alternative treatments like corticosteroid. I think that is what we have to keep in mind. So what is the real world experience in these cases? The number of patients, so many diabetes is common. DME patients receive fewer injection as compared to the neovascular AMD. That has been everybody's experience because they have multiple problems. These patients miss injections due to various reasons, and most receive suboptimal treatment. And that is how this results in the progressive visual loss and suboptimal outcome. So corticosteroids, we know we have Ozurdex, Iluvien we don't have, we have triamcinolone, and it is indicated in unresponsive to anti-VEGF or chronic DME. Pseudophakic eyes especially, I think we can be more liberal, and lower risk of glaucoma, or those patients who have a low risk of glaucoma or who have a significant cardiovascular risk, we can use it. And I think considered for treatment of refractive DME, especially if the recent cardiovascular event has happened, efficacy is comparable to anti-VEGFs for DME in pseudophakic eyes. This everybody has shown. And as an adjunct in cataract surgery, of course, is important one. And cataract and intraocular pressure rise can occur in these cases. I'll show you one example here. This 72-year-old lady who is still under treatment with us. He had received 9 Lucentis and a lot of focal grade, had MI and stenting in between. An happy lady, 624, 636. So she was like a recalcitrant DME like this. We offered her Ozurdex in both eyes. You can see the Ozurdex has been given. She improved remarkably. The entire fluid went away, which she was not going with anti-VEGF at all. And obviously it did recur, and we gave second injection. I think she has already received by now. She's receiving fourth injection each eye. And I think she's doing very well and is happy with the treatment. So the study here has already concluded that treatment with Ozurdex is associated with a significant improvement in visual acuity of 4 lines 20 TDRs later in cases of DME refractive to anti-VEGF therapy. That is the way the case I have shown. And what about DME surgery? I think it is beneficial for functional and anatomical outcome. Already highlighted by Professor Atul that ILM peeling in tractional DME is still controversial. We don't know. Some of them, they may lead to thinning of retina later on and do worse outcome. I just sharing one, this lady long time back coming to me and received grit laser treatment earlier, then lot of injections, 6 Avastin, 6 less Lucentis. And she was afraid of surgery. All the time she was being told, because she wouldn't, once she worsened, then finally in 2015, she was taken for surgery. And you can imagine how good she still improved 612. So surgery has a place in tractional DME, and they do very well. And this was without any ILM peeling, and that is what was done. So there are economics of diabetic retinopathy management, especially in our country. Individual pays for the treatment in our India, as well as insurance cover, and the government support is limited. And the treatment in such cases, which are chronic diseases, the cost and diverse sort of a scenario, we have a problem. So we have to modify. We have to even go sometimes to triamcinolone 2 milligram or something, but we have to treat these patients. And the standard of care with some rider need to be followed. So often the patients are here under-treated and under-monitored. So I would like to conclude my talk with that good metabolic control improves the outcome. I think that we should not forget all the time. We should remind ourselves, we should write down all those investigations which I mentioned in the middle. And anti-VEGFs are the first line therapy in center-involved DME. And 1/3 are non-responders or a recalcitrant DME, which may require alternative therapy with steroids or some other therapy, or maybe, I don't know about the combo treatment which talked earlier. Steroid may reduce treatment burden. This we realized during the COVID time, and we gave in some of them steroid Ozurdex injection, and at least they were good for longer time. And the vitreous surgery is required in tractional DME. Thank you very much for your attention.